Hi everybody, so it's Chat with Caroline time again.
Really keen that the questions you ask, as much as possible, are linking to the things that we're talking about as we go forward. I'm also keen that I think we'll start to theme these chats, and I'll probably invite different guests to be part of the chat with me. But I'd really like to hear from you. What are the themes and things that you'd like to have us talk about? So after today, this chat is going to go onto our website, and on that website there'll be a link to suggest what themes we should be focusing on. So please spread the word, get your thinking hats on and suggest the themes, and then we'll start to give more notice about those, and I hope then go to different areas of the trust. So there could be about clinical services, or it could be about themes that cross-cut all of us, for example values and behaviours. So get your thinking hats on and let me know, that would be fantastic. So also a reminder, during the chat, just carry on asking questions, and then as much as possible I will answer the questions during the chat, but where we've not had chance to answer all of them, as we have done before, all the questions will go on to our website and you'll be able to see the answers. So thanks ever so much again. Now, I'm trying to keep my just little overview quite short because I really want to get to you guys and hear your questions. But our real focus in the last couple of weeks has continued to be in our mental health services. As everybody knows, we had our CQC inspection during June. We had some really great feedback for our dental services and our children's inpatient services. Again, really well done and thank you. And as expected, there are some real concerns about our adult mental health acute pathway. Now, we've heard from the CQC in the last week or so about serious concerns, particularly around our mental health decision units and around our 136 place of safety suites. So we've got to take some urgent actions around that. They're not unexpected, and after the NTW review we already had an improvement plan that everybody had agreed locally, regionally and nationally, and our improvement actions are just becoming more urgent. It's not necessarily different things to do. So our original plan was that we would bring community services on board, increase our staffing, really get our crisis teams to be working really productively and really proactively with more staff, working well with the community teams and working well with our inpatient areas. And as we bolstered those teams, we had planned to close our mental health decision units. What it means is we've got to now bring those closures forward. So it's likely we're going to be writing back to the CQC and asking them to support our improvement plan, but it's likely that those units are going to be shutting in the next few weeks in a phased approach. Really important that staff working in those decision units, we hear their views, we listen to them, so hopefully you've started those conversations with your managers, and again would welcome your thoughts and views. But where we really need to get to is that we support patients not to come to A&Es where they don't need to come to A&E, that they're well supported to stay well at home, that when they're in a crisis they have really good crisis support through crisis home treatment teams, through crisis houses for example, and then when they do come to hospital they're responded to in a really timely way and can access beds. So our two really urgent actions at the moment are seeing how can we get more beds. We know that overall we probably have got enough mental health beds. We need some more rehabilitation beds and some more learning disability beds. But at the moment we're working particularly with the private sector to see what is it we can buy from them in the urgent short term. And then a big priority is increasing our staffing, and that's mainly in our liaison teams, in our community teams and in our crisis home treatment teams. So anything any of you can do to encourage staff to come and work in the trust would be enormously welcome. So it is a positive time, it's a very challenging time. We need to think really broadly about what workforce we can bring into the trust, but we also need to think carefully about who we can be partnering with. So working with the voluntary sector, we don't necessarily have to be employing the staff, we just need to make sure we've got really good partnerships. Really thinking about different types of workforce, so peer support workers are really important and we need to continue to invest in those. Apprenticeships, advanced nurse roles, advanced first AHP roles, all sort of physicians associates. So we really need to be thinking innovatively. So my key message there is mental health pathway, acute pathway, is very challenged and is a high priority for the board and the executive team. We've also, I'm really delighted, in the last week appointed a new improvement director. We're just doing the usual HR processes at the moment, and I'm hoping in the next day that we'll be able to get some comms out about who we've appointed. Really delighted with who we've appointed. Very experienced improvement director that I think will really help. And she's really keen to set up an improvement and innovation academy, really focusing on quality improvements as well. So hopefully that's something that will really benefit you as frontline staff. Then just a couple more things I wanted to mention. It's really important for me that we start to create the culture where people can speak out, speak up, get heard, and we make improvements. So a big part of our listening into action approach is starting to help us to change our culture and to do that. So we've had this week our first cut of our listening into action feedback. Amazing that we had 65% of you that filled in the LIA survey, and really, really massive thank you. The survey was actually a little bit more positive than we expected it to be, so I'll be sure to get those results out really quickly so that you can all see that. And we've had over 6,000 suggestions for improvements. So we've got 4 clinicians who've been appointed, as you know, in our listening into action team, along with our OD team, who are avidly working through those suggestions. And on a weekly basis, we're going to be telling you what are the things we're doing. So we're really wanting to get some energy around this. And then in September and October, we're going to start our first listening workshops around some big themes. And the 2 themes that we're going to start with are people with a personality disorder and really strengthening our response and services to those people. And then secondly, our urgent acute pathway, particularly our 12-hour breaches and our 136s. So we've got clinical leads and managers identified for those. And again, in our weekly LIA catch-up, we'll be giving you some more information. But a really big thank you to you. And then finally, I just wanted to say that we've made a decision in the last few days in terms of our Freedom to Speak Up Guardian. Matt Joyce, who's our current Freedom to Speak Up Guardian, who's also our Head of Patient Safety, is leaving the Trust. Well done to Matt. He's got a role over in Wales, an interesting system in Wales. And we're going to separate out the roles. So we're going to have a dedicated Freedom to Speak Up Guardian. Really important for me that this is something that is given true attention, and I know that the chairman, David Eva, is very keen that we continue to support people to speak up. So we'll be advertising in the next couple of weeks a new Freedom to Speak Up Guardian. Please look out for it, and please do think about applying for it. So thank you very much. I'm now going to pass over to Stuart, who's here in the studio with me, to help to let us know about what are the questions that are coming in. Thank you.
Thank you, Caroline. Yeah, we've had a few questions in actually while we've been on air. So thank you for people who've posted. And just a reminder, you still have time to ask your questions using the chat facility on the screen next to the video player. Okay, so the first question, Caroline, is from Chris. It's quite a long question, so bear with me. It said, you're a massive fan of peer support workers, individuals with lived experience working within mental health teams. This is my role at the moment, and the difference we are making to people's lives, recovery time and throughput is obvious to me in the context of my daily work. Further funding is often dependent on results, but I'm not sure the evaluation of our 12-month pilot is capturing the true impact that we're having. What research design methodology would you use to process and outcome evaluate the success of a peer support pilot?
So really, really great question. Thank you ever so much. And as I've already said in my introduction, peer support workers are essential. There's plenty of evidence nationally around the impact of peer support workers. And my personal view is that I don't think we need to spend lots of energy in evaluating pilots. I think we need to get them scaled up and invest in peer support workers. I'm delighted that our new Director of Nursing, who'll be starting with us on the 1st of September, Maria Nelligan, has got a real history of supporting peer support workers, and I know that she'll be personally championing this. So as we start to think about growing our workforce across our mental health pathway, we really need to ensure that peer support workers are embedded. Really important also that people who with lived experience of mental health, learning disability and community services are encouraged along to move into the pathway of becoming a peer support worker, something that in previous trust I've spent a lot of time and energy. It goes back 20 odd years for me, peer support workers. So really important and a great question. Thank you very much.
Thank you. And a question from Tracy. It's about mileage and of district nurses. Tracy is a district nurse and they haven't any choice but to drive miles to their visits. And it seems unfair that while endeavouring to meet service needs and cover more areas, staff are being penalised heavily after a certain amount of mileage has been claimed for. Talked about insuring cars, MOTs, etc. How is this fair? The question was in relation to mileage expenses being paid at a lower rate after 2,500 miles. The lower rate is significantly reduced. Why doesn't the mileage expense rate remain the same?
Yeah, so again, a really good question, and it doesn't seem very fair, does it? So I think we've got an agenda for change national contract, and I think the agenda for change national contract says that after 3,500 miles, the mileage rate goes down, and I think that's linked to that the mileage rate is more than the value of actually the cost of actually putting petrol into your car. But I think for me, it's really important, and I'm aware that running a car isn't just about putting petrol or diesel into your car. It's the whole cost of a car. I think it's really important for me that we don't want our staff to feel demotivated by, for example, this. So I think what we'll do is we'll take it away and we'll look at, can we be more flexible? Can we go outside of agenda for change and see if there's anything we can do? So I'll commit to that, and I'll ask through Deb, our head of HR, to take the leadership on that. So again, important if it's affecting people's way they're feeling about the trust and being valued and obviously paid for the work that they're doing and the expenses they're incurring. So thank you for that.
Thank you, Caroline. Maxwell's also asked a question. It's a fairly long one, so again, bear with us. How, as Chief Executive of LCFT, you would demonstrate continuous improvements against the 9 indicators of WRES, especially the ones about a workforce that represent the community we serve? Very senior leadership of BME background within LCT and reducing the high rate of disciplinary matters with BME staff. More transparency and timely resolution. Thanks.
So really important, and thank you for the question. Something that I feel really passionate about. In my previous trust, I personally sponsored equality, diversity and inclusion and set up an inclusion whole board. Something that we need to take seriously, and again it's one of my priorities. I haven't yet got to understanding properly what we're doing and what we can be doing more of. I know we have an equality lead, and I know that through the nursing workforce, Julie Seed is currently meeting with our BAME nurses and saying what more can we be doing. But it's something going forward that I will be personally really sponsoring and seeing how we can increase our diversity. And we cannot, on any account, tolerate that there's different experiences, for example, different HR processes being applied. But I guess what I'd say is we need the enthusiasm, ideas and support from you. So again, this might be something that we decide we want a listening into action theme around. Again, let me know your thoughts and views. At the moment, that hasn't come out massively as a theme for listening into action, but would really welcome your thoughts and views about that, and we could then get a group up and running. It needs, from my experience, really needs to be led from people on the front line who are experiencing the diversity and inclusion issues.
Okay.
Thank you very much.
Question about meeting rooms. It always comes up. It's quite a contentious issue even here. Should it be acceptable to cancel all room bookings from 2 of the 6 meeting rooms at Sceptre Point at 16:10 on a Friday, taking effect the following Monday? This is unfair on people who have meetings booked, including one-to-ones and team meetings, that must now be cancelled at such short notice with only 4 small meeting rooms now available for building of this size.
Okay, so thank you for that. And again, a good question, and understand that must be frustrating, and I can only apologise that it was such a late time in the day to inform people. So the context to this is when we've had the notices from the CQC, we've had to act very urgently, within 28 days. So we've set up centrally a clinical improvement team led by a community consultant psychiatrist, Ewan. We've had to identify urgently a room for that clinical team to be based in the headquarters, and hence why the CAMHS team have moved out of their team, and I believe with the PMO team have taken up a couple of the meeting rooms. So we still have 4 meeting rooms. I understand and can only apologise for the fact that it was such late notice, and maybe we could have and should have let people know. I think that we certainly could have known a few days before, but it's something we did within a week, and that is really just demonstrating the urgency of the issues that we have.
So I've got a technology question for you now. The recent new Samsung SM G390Fs, the work mobile phones are too slow to respond and are unable to take any further apps recommended from the trust, as the internal memory capacity is unable to cope with any further downloads, which is making the mobile slow in response. Also, why is the Wi-Fi connection so poor in trust buildings on these mobile phones?
Okay, so we've had lots of feedback, from listening into action, from the 6,000 suggestions for improvement we've had from you. And one of our listening into action big themes is definitely going to be digital. Again, from my previous trust, this is something that was a big issue, and we went through diligently the improvement programme. In terms of the Samsung phones, the advice I've had is that we can use them, if you've got Wi-Fi, you can use them through the internet, not necessarily through the 3 or 4G. But I have to say, I'm not a technical expert. So what we'll do is we'll put the answers to that with an email address of who you can contact for more information onto the website after this. But I guess the most important message I wanted to get through is that there's lots of frustration from people around IT and digital, and we need to be working collectively to continue to improve this, and we will do through listening to action.
Thank you. I would like to know why the MHDU staff have not had any written communication about the units closing. So far this has been verbal, and I believe that staff should be treated with a little bit more respect and have the situation and their rights in terms of job security, alternative roles clearly explained to them.
Okay, so again, I can only apologise that it's a difficult time for people. I hope that people understand the context that I've explained earlier on. So the CQC have written to us, they wrote to us a couple of weeks ago, maybe nearly 3 weeks ago, and we have to respond within 28 days. So for us to develop our plan for the mental health decision units, we couldn't just do that in isolation as a trust. We've had to have lots of discussions. Only yesterday I had lots of discussions with all our CCGs. Last week I met with our regulators and the team, and we have to take everybody with us with our plans. We then have to write to the CQC, we've got about another week to do that, suggesting what our plans will be, which will be a phased approach to the closure of the MHDUs. Only when the CQC then write back to us to approve that can we start a formal process. So what I'm really keen is that we talk openly with staff at the time we know the information, so we're completely open and transparent, and I hope that's what's happened and that you understand the context. But in terms of formally writing to staff, it's just difficult to be able to do that because we won't have the clarity until we hear back from the CQC. But we need to engage and listen to you and get your thoughts and ideas through discussions. So thank you for that.
Okay, just a few more questions, Caroline, before we end the session. What are the plans for the Children and Family Network? Are we moving to a locality-based model? And if so, what will this mean for CAMHS?
Okay, so I think most people will know, and I've been talking about it through the chat with Caroline, we've talked about it through the engage process, that we are thinking and planning to move to a locality model for all of our services as a starting point. Now it could be, we are completely open to thoughts and views about what our structures are going to look like. And I'm also very aware that the previous reset process, people have had lots of negative experiences of. So it's really important to me that we have the principle of no change about me without me, and we talk and we listen and we co-produce. So in terms of children's services, I'm very open-minded and open to thoughts and views as to how we should be rethinking about children's services. It could be we decide that they need to go into a locality model. They need to be very locally provided, working with partners across social care, with education partners, with health partners. It could be that we decide we want to keep them together as a specialist service. There will be lots of our services that we will want to keep together, and we'll have to co-produce that structure that will enable that to happen. So very open-minded. Russell Patton, our Director of Ops, will be leading this whole programme, and very soon we'll start a process of listening with workshops and real co-production. So children's services, get your thinking hats on and start to think about, should we be moving into a locality model? Should we be keeping services together as a specialist teams? And there's going to be pros and cons of both.
Thank you. I have recently attended some in-house training and been informed that certificates of attendance are no longer issued. As a qualified nurse, having a certificate of attendance is useful for revalidation and to demonstrate you have actually attended participatory training. From speaking to other nursing colleagues, they feel the same. Please, can certificates be issued again?
Yeah, okay. Again, understand that. And we're in the process at the moment of upgrading our whole training systems through HR. The new system that we're looking to buy will automate certificates for people, so I think that'll be much more helpful. So going forward, and that might be something I can give you some more information in terms of timescales. We can pop that onto the website when that's going to happen. Thank you for that.
Thank you. And your final question, unless there's any more last minute questions, this is it for today's chat with Caroline. And it is, I do not attend Engage, and I've heard there will be another organisational restructure reset too. Although I was not adversely affected by the last reset, I am friendly with lots of people who were affected. I heard their stories, saw their tears and distress, and was very unhappy. A lot of very good people that gave good service were forced out, and many of those that stayed are still scarred. Can you offer any reassurance that the next change will be handled with more care?
So really great question, and that's something that I've heard repeatedly since I've joined. It's absolutely essential that the way we change services has to be done in partnership and we treat people with care and respect. What we can't do is say we won't experience change. We'll have to continue to change, improve and transform. What we can do is give assurances that the way we manage change is with people in collaboration, and it's fair and there are fair processes. So I've done a very similar management of change in the trust that I've just come from. We moved into a locality model. It took us a while to achieve that. We went through different phases to achieve that, and overall I think staff were very positive about the way that was managed. It's absolutely essential for me. So I need to hear as we're going through this process, if people are experiencing anything but a positive. It doesn't necessarily mean that everybody's going to agree with the change, but the processes we use, the collaboration is absolutely essential. And I'm also hoping that lots and lots of people will get engaged with their thoughts and ideas about how we can move to a locality model. Nationally, that is a massive priority. In our system, we've already got an integrated care system across Lancashire and South Cumbria, and we've got integrated care partnerships. So something that is really, I think, going to benefit our service users and carers is that we move to an ICP model. And many of our services are already working geographically, and that we really maximise the partnership working with our partners so that, most importantly, service users will receive integrated joined-up care. So thank you very much indeed, folks. From now until the next chat with Caroline in a couple of weeks, be thinking about any questions. Really keen that you suggest themes going forward so that we can have different people with me doing the chat and we can focus on different areas. Really keen that we try and keep the questions live and they're focused around what we're chatting about. But thank you very much indeed and hope you enjoyed this session.